Welcome, everyone, and thank you for joining us. My name is Mona Vijay Kumar, and I'm a graduate student in the Masters of Architecture Studies and Urbanism program at MIT. I'm currently pursuing my independent summer research with the support of MISHTI India, and also working as a research assistant at the Civic Design Initiative Lab at MIT. The second wave of COVID-19 pandemic in India has paralyzed the country for several weeks. While the peak has now passed, the country continues to struggle with high infection rates in many parts of the country. Coupled with a vaccine shortage and the need to vaccinate a population of 1.3 billion. This second wave in India has also significantly affected the rural areas in ways in which it didn't in 2020. Before we proceed, I invite everyone in the session to take a couple of seconds to reflect and acknowledge the grief each of us have experienced, and with that, also realize the importance of finding meaning and hope in our lives during these unsettling times. Thank you for joining me in the moment of reflection. Moving forward, through the lens of policy, public health, and journalistic reporting, we will hear from experts in the field who will share the perspectives on the current situation and opportunities for changing practices in the future. We have three speakers joining us today, Dr. Gagandeep Kang, Dr. K. Srinath Reddy, and Ms. Anusha Bailey. We are delighted to be co-hosting this event with MIT, South Asian Alumni Association, and MIT India, part of MIT's flagship global education program. Just a quick note on the format. We'll be hearing from our panelists first before we move to the Q&A section. So please do keep note of your questions as we go along and feel free to write them in the Q&A box. With that, I'm delighted to introduce our first speaker, Dr. Gagandeep Kang. Dr. Kang is Professor of Microbiology at the Wellcome Trust Research Laboratory, Division of Gastrointestinal Sciences at the Christian Medical College, CMC, in Vellore, and a world expert in vaccines. She is a fellow of the Royal Society and also the first Indian woman to be elected to the Fellowship of American Academy of Microbiology, and the only physician scientist to receive the Infosys Award in Life Sciences. Her expertise and inputs on COVID-19 pandemic has been of great value across the nation. Dr. Kang is also one of the members of 12-member National Task Force for Oxygen Distribution set up by the Supreme Court of India for oxygen distribution across the country. Spinning on that, I invite Dr. Kang to provide us with an overview of her role in the 12-member task force and highlight some of the key challenges on ground during the start of the second wave in India.
Thank you very much, Mona, for the introduction, and thanks to everybody for having me here. To talk about the National Task Force is a little bit difficult because it came as something of a surprise. I've been on various kinds of technical advisory committees before, but never one that was appointed or recommended to the Union Government of India for the purpose of trying to solve problems that the Supreme Court had taken cognizance of. This was at the beginning of May, at a time when India was really struggling with supplies of oxygen, with supplies of drugs of various kinds, where there were horrific scenes of what was happening inside hospitals, outside hospitals in Delhi, as well as what was happening in other states. The purpose of the National Task Force is to put together a group of medical experts, administrators, to be able to help the government with some of their activities. The first thing we were tasked with was really to look at oxygen supplies and try and figure out if there was a way of better allocating oxygen across the country. We also have many other terms of reference that include research and innovation, drug supply, and future preparedness. The task force is going to be in existence for 6 months in the first instance and has initiated its work with the government as well as with external experts. In the work that we've done over the last month and a half, I've learned a lot. And one of the things that I have learned is just how complicated it is and how much the government has done in terms of being able to rationalize oxygen supplies. When you work in a hospital like I do in southern India, oxygen is something that you take for granted. Our hospital is a large hospital. It's about 2,700 beds. And we've had a liquid oxygen plant for a really long time. But in Tamil Nadu, which is a state that generally has good supply systems, it came as a surprise when about a month and a half ago, we were hearing about similar problems in Chennai as had been seen in Delhi. People running around trying to get cylinders filled for their relatives, hospitals telling patients that we can provide you with a bed, but you have to bring your own oxygen cylinder with you. At the same time, my husband and I were running a teleconsultation service for people all over the country, trying to advise them about how to manage their patients at home because there just were no beds available. So the National Task Force has looked at the situation, which has eased by now, but is now very invested in planning for the future, in thinking about how you solve problems of supply for a country where the oxygen is made in a place that is 1,500 kilometers away from the place that actually has the need for the oxygen. So we have now come up with recommendations for distributed manufacturing, distributed storage, and also what the requirements will be, not just in urban areas, but in rural areas as well. Oxygen was only one of the challenges that was encountered during the second wave. I've already mentioned the challenges of people finding enough beds to be able to admit people. And I think it's important to recognize that while some of this could have been predicted, some of it could not. In hindsight, we know that a lot of the challenge that we faced was because we were dealing with something that we had not seen last year. We now know that the Delta variant, which was responsible for a lot of the disease, particularly in Western India and partially in Northern India, is a variant that is about 2.5 times more infectious than the variant we dealt with last year. Part of the reason for the exponential increase is its rapid transmission and the fact that people deteriorated much more quickly. This has been shown by studies that have looked at viral loads in patients and found that you can have somewhere between 10 and 100 times more virus in people who are infected during the second wave than were infected in the first wave. So we were dealing essentially with a different virus. So this could not have been predicted, but what we could have done better is not had different behaviors. For example, what happened during elections, what happened with religious festivals were avoidable challenges that we brought upon ourselves. During this time, there were a lot of, Mona, you spoke about the grief, the sadness, the amount of struggle that people went through. But I'd really like to look at also at the accomplishments that we've had in India that we should recognize. One of these is the fact that India was able to scale up and maintain testing at a reasonably high level. About 2 million a day is not an insignificant number, even though we have a very huge population. The second thing I'd like to talk about, and there are lots of disappointments in that area, but the area of treatment and treatment protocols. I think the skills of ICU physicians and doctors in many well-known hospitals in India is one of the reasons why we had a fair proportion of patients surviving in hospitals. The early use of steroids, particularly inhaled steroids, kept a lot of patients out of hospital. To counterbalance that, we also had the overuse of oral steroids, which was one of the contributing factors to the mucormycosis that we also saw as a huge challenge in the second wave. Before I finish, I'd just like to comment on vaccines and where we are. I think we keep belaboring the fact that there is a supply constraint, that we are unable to vaccinate people as quickly as we would like. But it's also important to recognize that India has given out hundreds of millions of doses of vaccine now. We are heading towards 20% of our population being covered, and we need to cover almost 1 billion people. That means 2 billion doses of vaccines. While we have a long way to go, we are once again, after some hiccups in the middle, beginning to increase vaccine coverage. And I hope that this will be an upward trajectory, that if it doesn't match the pattern of the second wave, at least matches in increase what we saw during the first wave, so that we can cover as much of our population as quickly as possible. I'll stop there, and once again, thank you for having me here.
Thank you, Dr. Kang, for a great overview of the task force and the current situation. And with no doubts, I would correct, like India's medical experts and frontliners are going beyond their capacities to save lives and manage the pandemic. And I would also like to highlight the pointer you had spoken about decentralizing the location of oxygen plants in India going forward to better equip themselves for the coming challenges. And moving forward, I would like to take the opportunity to introduce Dr. K. Srinath Reddy. Dr. Reddy is the president of Public Health Foundation of India, PHFI, and formerly headed the Department of Cardiology at All India Institute of Medical Sciences, AIIMS. Under his leadership, PHFI has established 5 Indian institutions of public health in different regions of India. He is a Padma Bhushan awardee. He is also the advisor to governments of Odisha, Punjab, Haryana, and Andhra Pradesh on public health. Widely regarded as a leader of preventive cardiology at national and international levels, Professor Reddy has been an active researcher, teacher, policy enabler, advocate, and activist. I would like to kindly invite Professor and Dr. Reddy to provide us with a brief overview of the public health system and public health policy in India and the work at PFHI.
Thank you very much, and greetings of the day. India's health system is a mixed health system which has evolved by default rather than design. With a strong public sector emphasis at the very beginning, after we began our life as an independent country, progressively the public sector declined in presence and dwindled in influence because of inadequate resources being allocated. And the private sector started coming up in the mid-1980s, and then gathered force suddenly after the liberalization and globalization set Indian economy free, both for private investment as well as international investment in the private sector healthcare facilities. However, it is a system which significantly revolves around the responsibility of individual states to deliver health services, while the central functions, as mandated by the Constitution, also exist in the area of health professional education, as well as in research, regulation of drugs, pharmaceuticals, vaccines, devices. A variety of national health programs initiated by the center are also implemented by the states and are part funded by the central government. So while the delivery of health services is principally the function of states, much of it is also funded and also involves central decision making and steering. There are also several other central institutions and a number of central services which run their own health services, including autonomous institutions like the All India Institute of Medical Sciences, which has now been replicated across several states. Then you have the Railway Health Services, the Armed Forces Health Services, and so on. Therefore, you have a mix of several services, but predominantly, each state is responsible for the delivery of health services. However, apart from the national health programs, the management of epidemics is very much the role of the center. And indeed, in the COVID pandemic, the central government, even in 2020, invoked both the Epidemic Act as well as the National Disaster Management Act in order to take up several of the powers of central coordination. And indeed, that worked very well with the states and the center working quite well in tandem in the first wave. And throughout 2020, we saw fairly good examples of multi-departmental and multi-state collaboration, and with the central government as well. Unfortunately, that did not present itself as a very strong feature in the second wave, because by this time, politics had taken over, and competitive politics ranging from local body elections to state assembly elections made the harmony of center-state relations that was very visible in the first wave a bit of an absent feature in the second wave, and some of the harmony was replaced by confrontation and lack of cooperation at various levels. And that also affected both the lack of anticipation as well as the late response to the second wave, which was less coordinated than in the past. But we also recognize that institutions have to play a strong role in supporting both the central and state governments. And we at the Public Health Foundation of India have been working along with several other institutions in providing technical support in very many ways, both to the state governments as well as the central governments. We are an institution which extends across the country through several Indian institutes of public health, engaged in postgraduate education, training, and research, and providing technical support to governments as well as to non-governmental agencies, the development of appropriate technologies for primary healthcare as well as advocacy. So we were considerably called on by a number of state governments and some of the central government bodies as well to provide that technical support at various levels. In terms of epidemiological analysis, in terms of training, both healthcare personnel as well as primary care physicians and others as well, but also supporting health policy reviews and also in public communication. But we recognize that there have been several challenges to the whole health system in the country. And one of the lessons that we must take from the second wave to the third wave is you cannot have a swift and strong surge response to a public health emergency if you do not have an efficient and equitable health system functioning in the steady state. If you have been relatively incapacitated in the past, as many of the state health services have been, then you cannot suddenly pick up speed when it comes to a public health emergency. Some states have done well in terms of their response. Other states have not done as well. And this has been the feature even before the public health emergency set in. But the inherent weaknesses of several state systems came to the fore during the emergency, in particular, when the stress was even greater. So that is a lesson that we must carry forth in trying to strengthen our health system at various levels. And this is not only in terms of advanced care hospitals, and certainly not the dependence on ventilators, but ensuring that our primary healthcare system is substantially strengthened, and it is strengthened both in rural and urban areas, because there are several functions, right from early case detection and supportive home care to contact tracing and many other functions which need to be undertaken at the primary care level. And unfortunately, our weaknesses in urban primary health care have also been reflected here in late recognition of cases, poor contact tracing, and inadequate support for home care, which led to a lot of rush on the hospitals. So these are some of the things that we do need to correct as we move along in a preparation for the third wave. And there has been a lot of hue and cry as to whether the third wave will affect children much more disproportionately. There is really no evidence to bear that out. Nevertheless, as we prepare our health systems for better functioning, we certainly need to also increase our pediatric care capacity, even as a matter of necessity for other reasons. Therefore, that level of interest in pediatric care is certainly helpful, but it should not be disproportionate in terms of what is likely to be the outcome in the third wave. Now, will there be a third wave? And what magnitude will it be of? Well, if we actually follow all the steps that we ought to take in order to prepare and respond efficiently, then we can keep the third wave to a mere ripple rather than a large tidal wave, irrespective of the variants, because we do know that public health measures like masking, operating mostly in ventilated places, avoiding crowds, preventing super spreader events, will prevent transmission of any variant of the virus or the virus itself in the original form or any variant thereof. Therefore, public health measures must be ensured along with much faster pace of vaccination. It is very clear that natural infection with the virus itself gives uncertain level of immunity based on the amount of variable viral load that a person is subjected to. And therefore, it can be relatively evanescent or could be long lasting. It's very indeterminate. But a vaccine with a fairly standardized dose of antigenic exposure, and particularly with a priming and a booster dose, can give a much better immunity. And we now know, even from some of the experiences in Brazil as well as in the UK, that by the time you reach a 60% vaccination mark, the deaths come down markedly and the infections also come down markedly. So that is where we ought to move ahead, even as we pick up the pace of vaccination, and hopefully by July, August, we should have a much better supply chain with more vaccines coming into it. We must ensure that some of the follies that actually made the second wave such a huge challenge by the kind of careless behaviors that Dr. Kang referred to, we ought to really prevent it, because it's not merely the behavior of the virus or the variants that emerge, but it's also human behavior that matters quite a lot, and the system behavior as well, in terms of system efficiency and coordination, in terms of appropriate data systems for early recognition of what the challenges are, of mounting prompt coordinated responses. All of these are going to be important determinants, and we cannot think only in terms of linear dynamics of transmission and linear responses, because the virus itself is a complex system, and the health system is a complex system, and we ought to really think in terms of management of complex systems with more coordinated responses across multiple areas. And that's the lesson we have to take home for the third wave. Indeed, we must ensure that even as we prepare for the third wave, and we are still to come out for surety from the second wave, because the lockdowns in various states are just easing, and already some of the crowd behavior is alarming in terms of rushing to malls and rushing to holiday spots. And we need to now rein that kind of behavior. Otherwise, the second wave itself may get protracted, or there could be a rebound. But if we actually do manage to make sure that at various levels we act with determination, then we may be able to keep the third wave down to a ripple rather than a tidal wave. And that's what we must indeed aim to do. And utilize this opportunity for ensuring that our health systems are strengthened, primary, secondary care with oxygen capacity beds, tertiary care also as needed, but a well-connected health system, right from home care to primary facility-based care to secondary care and tertiary care, all in a seamless manner, bringing in the public sector, which should be strengthened much more, but also bringing in the private sector as an able partner where present and willing. And we must make sure that this well-networked healthcare system, rather than some of the disconnected healthcare elements that we had in the past, will present a much better picture by the third wave. And lastly, we have frequently lamented how globally and nationally our economy has been taken down by the pandemic. And we now recognize, at least most of the decision makers do recognize, that unless we pay attention to health, economy will always suffer. And we do need to provide more money for health and get more health for the money by better allocative and utilization efficiencies. But if we continue to neglect health, economy will continue to slip on the banana peels of public health failure. And that is the lesson that we must carry into the third wave and beyond. Thank you.
Thank you so much, Dr. Reddy, for sharing an overview of a lot of pointers, starting from the role of states, medical system, economics, and how we need to be prepared for the third wave. I would just like to ask a follow-up question. If you would like to share some of your policy suggestions that the government of India can take into account for the challenges that are coming in future.
Well, we worked in a number of areas, but one of the areas where I felt at least we had some impact and influence was when the 15th Finance Commission set up a committee to try and address how health should also be looked at in the context of center-state division of revenues. Because the function of the Finance Commission is essentially to try and decide the share of the tax revenues that should go to the center and to the states. For the first time ever, the 15th Finance Commission decided to do a special chapter on health. It was never done before. And this was before the pandemic started. But they felt health in India was in a great state of neglect. They had seen several other failures of public health, and they decided something must be done to strengthen the healthcare systems. So a 6-member committee was set up, and I was a member of that, and we prepared a report, and we emphasized the need for primary care, particularly urban primary care, which was a neglected area. We also suggested how district hospitals must be strengthened, and also surveillance systems also being strengthened. We did not anticipate the pandemic at that time, but we noted the deficiencies that already existed, and several other areas of reform were suggested, especially in the area of the health workforce, how to train more allied health workforce personnel, and ensure that also the medical and nursing staff are also increased at various levels, and so on. These were actually submitted. They were in a draft form of the Finance Commission report, and the Finance Commission was about to submit the report when the pandemic struck. And all the deficiencies that we pointed out in our report as calling for redressal jumped out of the pages of the newspapers and out of the screens of the television in a most, very visible manner. And as a result, the Finance Commission called us back again and said, based on these lessons, what can we do? So as the first wave had just abated, we went back and then again framed additional recommendations, particularly in terms of both surveillance systems as well as critical care capacity, but again emphasizing the need for primary care systems, which can be comprehensive, well connected to advanced care in a bidirectional way. And these recommendations were accepted by the Finance Commission, transmitted to the government, incorporated into the budget of 2021, including the fact that urban and rural primary health care would be strengthened, the local bodies would be given a greater role, surveillance systems would be strengthened, and that critical care capacity also would be increased. So that is an area where collective technical expertise can assist even decision-making bodies, make a great deal of difference in allocation of resources.
Thank you, Shiv. Thank you for sharing that and also highlighting the need for decentralizing and also strengthening the primary care system in India. And that would, going forward, that would make a big difference in how we handle medical challenges coming in future. Thank you so much, Dr. Reddy. Moving forward, I would request viewers to send in their questions in the Q&A box. And up next, I take the opportunity to introduce our journalist on board, Ms. Anisha Bedi. Ms. Bedi is a special correspondent with The Print in India, a web portal with its headquarters in New Delhi. Besides covering political and governance-related issues in the national capital, Anisha has been covering the COVID-19 pandemic for a year and is part of the organization's COVID coverage team. Besides covering the pandemic in Delhi, she has traveled to several other states, including Telangana, Andhra Pradesh, Punjab, and most recently Rajasthan, to look at ground the impact of COVID crisis in various parts of the country. Before this, she worked with NDTV and Hindustan Times and is an award-winning journalist wherein she has been lauded for her gender-sensitive reportage while reporting on crime against women and violence in childhood. I would like to kindly pass the screen to Ms. Bedi to provide us with an overview of the current happenings and challenges in dealing with the pandemic, especially in the rural India.
Thanks so much, Mona. And of course, thank you to everyone at MIT for having me here today. Just a disclaimer before I begin, of course, Dr. Kang and Professor Reddy are the real experts. So I'm going to limit my narrative to from the point of view of a journalist and what I've experienced in the past 1 year, and more particularly in the past couple of months while covering the second wave of the pandemic, in India here. Some of the things that I'd be touching upon would be, of course, there has been a visible shift in terms of the spread of infection from urban areas to the rural hinterland of the country. So maybe I'd like to share some of those experiences and also talk about what kind of challenges we as journalists who were out reporting, doing some ground reportage encountered while doing so. And of course, as the webinar points out, also perhaps see what we've learned and what we can do better, especially at the backdrop of a likely third wave of the pandemic. But before I begin, just to kind of set the context and give an overview and talk about when exactly did the stories of the second wave of the pandemic, started coming out in the public, would be to say, I think somewhere in mid-April. Now, it's important to understand that January onwards, our cases had actually started declining here in India. And Delhi, which is the national capital, as well as Mumbai, which is the financial capital of the country, were among the first to sort of experience a visible surge in the number of cases that it became worrisome. Delhi, of course, there was a decline in February, but Mumbai started seeing a visible surge in March. And of course, besides the fact that Mumbai, the population is much more, but just to give you an example in terms of data, there were 4 times the cases in Mumbai, daily COVID infections, as opposed to Delhi. And I think it was around, say, January, we were reporting about 50,000 daily infections across the country, and we jumped to about 126,000 around April of 7th is what I was reading recently. So that's the kind of variation that we saw in terms of the numbers, when the second wave hit us. And to speak about Mumbai first, because that's where, the government officials and the machinery really woke up to sort of realize that this was a second wave, in the coming, when the chief minister there actually announced a Janta curfew, which is the lockdown-like restriction. I mean, they didn't officially call it a lockdown, but the kind of restrictions that were put in place were pretty much like that. And it was a couple of days after that, I think around the 17th of April, that about 7 key COVID hospitals in Mumbai ran out of oxygen. And there was an emergency, which I think included about 168 patients. And thankfully, to the credit of the government officials and the administration there, each of these patients survived. But the situation was quite grave. Even the number of deaths started increasing. And I personally can share an experience wherein my own family members, my sister, my brother-in-law, my 7-year-old nephew, who were all based out of Mumbai, were also contracted the infection. So while it was relatively mild for my nephew and my sister, it was a rather severe case for my brother-in-law. And the reason I mention this is, as a journalist who perhaps has access to government officials, can reach out to them through a phone call, I think I was still able to sort of reserve a bed, but I have to confess I was able to do that, and thankfully we didn't need it eventually. But it's important to point out that not everyone had that kind of access, and which is what, just like Dr. Kang earlier pointed out, that everyone was sort of running, and kind of there was this desperate plea for hospital beds, oxygen shortage. And soon after, this is what we saw play out in the national capital of the country, in Delhi, something that I've been covering very closely for the past 1 year, ever since the first wave of the pandemic hit us. And this is when people actually, there were desperate pleas, and they started reaching out on social media platforms, so to speak, asking for help to arrange hospital beds, oxygen, and particularly Twitter, for those of you who might be on it and are familiar. There were SOS calls for that matter. And the situation was so grave that testimony to that is how we saw medical superintendents and medical directors of key COVID hospitals in the national capital actually have a meltdown on national television. That's the level of helplessness that we witnessed, wherein they felt that they didn't have an oxygen plant. So again, it sort of cast the spotlight on how, our health infrastructure perhaps was not prepared or not equipped enough to deal with the kind of surge that we were witnessing, whether it's in the number of daily cases, whether it's in the number of deaths for that matter. And this is something that, again, I would like to bring in as a journalist, we encountered for ourselves, and not just me, so many of my fellow journalists, where there were people queuing up outside COVID hospitals, lying on stretchers and quite literally gasping for breath. So it was quite a sorry state of affairs for that matter. And while I talk about SOS calls, I think that brings me to a very significant aspect of the second wave, as Mona pointed out and wanted me to elaborate on, is what was happening in rural areas. Now, it's important to understand that while we here in, located or residing in urban cities have access to platforms like Twitter, people residing in rural areas, and mind you, 65% of India's population actually resides in rural areas. So these people did not have, they had low internet connectivity, or for that matter, did not have access to smartphones, or even understand that something like Twitter existed, where people were actually putting posts or asking, they were desperate pleas for that matter. So there was clearly a visible shift in that sense. And also, I think it took a while for everyone to acknowledge the fact that there were a large number of cases in the rural areas of the country, be it, states like Uttar Pradesh, Madhya Pradesh, Bihar, or even Rajasthan, which is where I spent, the last bit of April, I spent about a week, 10 days there, traveling across some of the remote districts to sort of understand as to how people didn't understand that something like COVID actually existed or did not want to believe it. There were people dying of what they call flu-like symptoms, even fever. So, and this is significant because please try and understand that the deaths that occurred were not being recorded as COVID deaths, something that even Professor Reddy earlier pointed out, which again plays out in terms of how something that has made international headlines as well, that how the number of COVID deaths in India are actually being underreported because these people are most likely had COVID, but there was no way to determine it. A lot of them were also reluctant to get tested for that matter. So I think a lack of awareness continued, which is surprising, even though there was so much and there was a public outreach program that was carried out by the central government, when the first wave hit us in 2020. But clearly there has been a lack of communication. And we also saw that play out as far as vaccine hesitancy is concerned in rural areas. A lot of journalists in India actually have done some fantastic reportage on that front in terms of highlighting how people thought that they would actually die if they took a dose of the COVID vaccine, how they felt that the fever that they got a day after getting the first or the second dose was not something they were ready to take in. So these were some of the things that we were noticing in the rural areas. Also, since I spoke about deaths, I think it's also important to talk about the long queues that we were seeing outside crematoriums, something that I've been reporting on right from April 2020, wherein the discrepancy in terms of the official death toll as well as what we were seeing play out on the ground was vast, if I may say so. Especially just to give an example, if you're seeing a state or say Delhi's health bulletin, you perhaps were seeing a daily toll of about 100 and 150 deaths. But as a journalist, if I was out and I was visiting, say, 6 designated COVID crematoriums in a day and literally counting the number of fires that were there, it clearly showed that there were much more for that matter. And some of these images have actually made it to page 1 of international newspapers as well, so to speak. So much so that even parks and public spaces here were converted into temporary crematoriums and burial grounds. And I remember this, that, towards the end of April, and that's something that has stayed with me. It's different when people call you. I mean, it's one thing when people call you and ask you for help because they think that you're connected to the government officials and you can help them as a journalist in terms of arranging a hospital bed. But it was the situation in the second wave that people were actually calling up and asking, I can't find space to cremate my uncle. Can you help me out, Anisha? And I'm not even exaggerating when I say this. And I remember feeling numb at that point because that's how crowded our crematoriums or burial grounds had become. And if you look at what was happening in rural areas, given that there weren't too many and the kind of taboo and fear attached to COVID bodies among these people who might not be literate to understand that, infection does not spread from bodies or that there is a designated crematorium for this, we were actually seeing bodies being disposed in open fields, even in the river Ganga, which is known as India's holiest river, again, something that has made international headlines as well. So I think that is where the work of journalists also became quite pivotal in the second wave, wherein they were taking it upon themselves to bring out these stories to kind of point out that the real death toll might be much higher than what was being reflected in the government health bulletins. Even in the river Ganga, I mean, we've seen a lot of local journalists actually sit in a boat, literally ride through that and actually kind of count the number of bodies they saw disposed. So these are just some of the things that we were seeing play out in rural areas. Besides the poor infrastructure, there were only primary healthcare centers, dispensaries, which perhaps weren't well equipped to handle the kind of COVID surge that took place in the second wave, for that matter. Some of these were also lying defunct. For that matter, just to give an example in terms of what we saw in Bihar, my colleague Jyoti Yadav covered these stories very closely. You can check out her work, wherein we actually saw a COVID hospital in Bihar, wherein even entering the hospital was a challenge. The area was waterlogged. You could actually see, there are visuals that have been captured where you could see pigs outside the hospital. About 2 to 3 patients were sharing space on a single hospital bed. And that perhaps also defeats the purpose of social distancing and isolation, which is key to, the COVID infection for that matter. And no healthcare workers to monitor the situation, let alone the SpO2 levels. So again, like I said, that these are just some of the examples that I'm pointing out. However, I think it's important to also quickly mention some of the work that was being done by good Samaritans who were coming out. For example, in Delhi and in several other parts also, actually, we saw what was being organized, what was called an oxygen langar. Now, for those of you who might not know, langar is actually a community kitchen for the Sikhs here in India, which is something they organize free of cost. Now, they were replicating this concept in the form of oxygen, where they were arranging oxygen cylinders, concentrators for people, and prioritizing it for people who might have low SpO2 levels. So I think if I had to really sum it up, I think second wave in India also sort of highlighted how we were sort of living of kindness of strangers, for that matter. That is not to say that the government did not rise to the occasion. Perhaps they did try their best, but clearly they didn't do enough, which is why we were actually seeing people out on the roads. And that is where I see, and I think those are some of the things we need to keep in mind while we look at a potential third wave ahead of us, which is to perhaps, really improve our health infrastructure, especially in rural areas. Also announce perhaps a rural infrastructure package, for that matter. It's something that the Indian finance minister also pointed out in an interview just the other day to a national television, that is something that they might consider. Besides that, also I think we need to keep in mind that even as individuals, we need to be careful whether it is not letting our guard down, something that we clearly did after the first wave in terms of organizing large public gatherings, religious functions, weddings, or even election rallies, the impact of which we've seen in the second wave. And last but not the least, also ensuring more transparency, for that matter, which is what I think can help even journalists like us put out stories in a more credible manner while confirming or corroborating death toll. There are supposed to be death audit committees that each state is supposed to have. But as someone who has been aggressively reporting on this issue for the past 1 year, I'm yet to speak to members of a death committee or death audit committee, pardon me, wherein work has been happening on a regular basis. There was one constituted in Delhi, and I've been chasing those people, but I don't think there's been much done on that front. So it'll be nice to see some sort of data or some sort of reconciliation of death figures come out in the public, on a public platform. And even in terms of policy, for that matter, just as my last point, as we've seen this recent debate play out in terms of, the gap between 2 doses of the COVID vaccine, wherein the government here took certain decisions which apparently wasn't backed by the advisory group to the government, which includes experts, health experts, public policy experts, as well as scientists. Something that we again saw come out in the public only when journalists broke it. This was a story done by Reuters just 2 days ago. So I think it's important for more transparency that we expect from the government as data and be it in the form of data or in terms of informed decisions like this, as that will only help us perhaps prepare better for a likely third wave. Yeah, I think I'd leave it here, and I couldn't talk too much about the challenges that we face as journalists, but I'm happy to take questions on that front since I know we're on a strict timeline as well.
Thank you so much, Ms. Anisha, and also sharing the perspective on the general public, how they were combating with the pandemic and the prudent role social media has played in speeding up the sharing of resources. And also thank you for mentioning and highlighting how the rural communities had felt neglected by the authorities of India. And also very grateful for journalists that are trying to forefront and share the stories that are coming up in rural India. Moving forward, and also I have a question for you, like from the chat. Since you had mentioned about the transparency on journalism, would you like to share some of your challenges on that aspect?
Sure. So I think one, as far as transparency is concerned, as I pointed out, it's something that we took upon ourselves, and we've also come a long way in terms of, I remember the first story that I did in May 2020 on the discrepancy in COVID death figures from Delhi actually included only the official tally from the Delhi Health Bulletin, which is something that the government gives out, vis-a-vis what I managed to get from from crematoriums. So that was one way of looking at it. But I think in this entire 1 year, we've also sort of learned how to look at that discrepancy in a more organized manner, and also to look at death registrations, perhaps also look at a larger duration or longer time from say 2019, 2020, 21, so as to be able to establish that there were excessive deaths or not. So that was one challenge, because a lot of this data is not available, on government websites or public platforms. So you either have to file an RTI or you have sources. So that was, of course, one challenge. And the other thing, I think something that most of us who've been on the ground faced is the mental health impact of it. The second wave, of course, made us realize that COVID had hit home. And I don't just mean to make a frivolous statement, but in many cities and in many towns for that matter, I can say it with a certain amount of surety that you would barely come across a family that hadn't been impacted by COVID, be it in some form or the other, be it their friends, family, or colleagues. So I think that kind of fear, even as a journalist, in terms of you might be bringing back the infection back home, or infecting your family members, or all those tweets play out in your head time and again, something that I've personally experienced. And it's a gradual process. Of course, things have become slightly better, but I think the grief that not just journalists, but a lot of frontline workers have witnessed is something that will take a while for us to get over.
Thanks for sharing that story.
Thank you.
To move forward, I once again thank all the panelists for your provocative and insightful lessons on the ongoing pandemic. Having you all here with us today could not have been more fitting and meaningful. We'll now open up our questions from the audience. So we have a question for Dr. Reddy. So someone's asking, Dr. Reddy mentioned that confrontational center-state relation resulted in bigger fiasco. Could Dr. Reddy provide a couple of examples of the difference between center and state decision behaviors that contributed to the spread of the disease?
Well, I didn't use the word fiasco, so let me correct that. I said the coordination certainly was much better in the first wave than in the second wave. One of the glaring examples came up, of course, not merely in terms of who was deciding on the lockdowns. In the first instance, the center, using the National Epidemic Act and the Disaster Management Act, to control, and then it was a national lockdown. In the second instance, it was the states which decided whether there would be a lockdown or not, and which parts of the state would be locked down, for how long, and there was a fair amount of confusion there among states and within states. But I think the biggest area of discord was in the vaccine policy, where the center initially was taking care of the vaccine for people above 45 years of age and people who are younger with known and documented comorbidities. When the center suddenly opened up for 18 plus age group and decided that the 18 to 44 age group would have to be handled by the states and they would have to procure their own vaccines directly from the manufacturers, national or international, and then also allowed the private hospitals as well as large private employers to compete with the states for getting the vaccines from the vaccine manufacturers. It became a very disjointed effort, and the states had to compete with each other. They had to compete with the private sector, and they also failed to get any response from global vaccine manufacturers who refused to negotiate with the states. They said they'll only negotiate with the central government. And that also led to a huge differential pricing. And the states actually were at a disadvantage compared to the center in terms of the price that was being levied by the vaccine manufacturers. So this caused a huge amount of discord, which led even the Supreme Court to ask some sharp questions. And finally, the policy has been partially reversed. At least the center said that it will procure the vaccines and supply the states. But the private sector is on its own now. And that again is a competition that is still on, in a sense of procuring vaccines from global manufacturers or even Indian manufacturers at differential prices. So there are a lot of questions that are involved here, apart from some of the other issues that rose related to the levels of control, the levels of data verification. All of that was being done at the center state level. And certainly the harmony that was visible in the first wave was not always reflected by some of the acrimony of the second wave.
Thank you, Dr. Reddy, for sharing that. Being mindful of the time, we'll have one last question, which is directed to the panelists. Would you recommend that an independent people's commission on the whole management of this COVID crisis be constituted by the civil society?
I'll start on that. I think a number of civil society organizations have already begun to discuss that, but I'm not sure how effective it would be in changing anything for this pandemic or for the future.
Thank you. And we'll close up on thank you all for joining us this afternoon. Should you have any further questions, or if you'd like to know more about the organizations and initiatives mentioned today, please feel free to reach out to us, and we'll be happy to point out in the right direction.
Let me just add one sentence to what Dr. Khan said.
Definitely.
The ability of any independent body to investigate and look at what might have gone wrong and what should be corrected depends on access to data. Firstly, good representative data, complete data as much as possible, but a fair amount of data transparency. If the data are not easily available, it's difficult for anybody, however independent, to come to valid judgments. So that's going to be a challenge.
Thank you so much, Reddy, for emphasizing the importance for the need for data. And being mindful of time, I would like to close up on our session today. Thank you so much, everyone, for joining us. Stay safe and healthy. Thank you.
Thank you.
Bye. Thank you.
Thank you.